Hello everyone, thanks for having me. My name is Haifeng Xu. I'm a PhD candidate in precision oncology at University of Oslo and Oslo University Hospital in Norway. So today my topic is about using proteomics data and also machine learning to predict the treatment response of a certain blood cancer. So I'm going to explain that later. So before we go into the details, I would like to introduce some keywords that are important to this presentation. So first of all, what is chronic lymphocytic leukemia? Chronic lymphocytic leukemia, which is also called CLL, is the most common chronic leukemia in adults. I think you also heard that in the second presentation in the first day. And the cancer cells start in the bone marrow, then go into the blood as a B-cell malignancy. CLL is initiated by specific genomic alteration that impair apoptosis of clonal B cells. But how to treat it? There are many drugs that can treat CLL. However, there is something that are very promising, which is called PI3K inhibitor. PI3K is a pathway that regulates cancer-related cellular process, so its inhibitor has been widely applied as a drug, as a treatment, as a cancer therapy, especially for lymphoma. Rublisib is a new generation of a PI3K inhibitor developed by TG Therapeutic, which has been used in a second phase clinical trial. That's an American company. And since we mentioned this is a prediction project, and this is a computational biology conference, you will think that what kind of data we are using. So I'm not sure if you are familiar with this phosphofluorimetry. It is kind of proteomics data, but unlike other proteomics data, it does not measure the expression of protein. It actually measures the activation level of a protein, but that's a simplification saying. You may check the details if you want. Yeah. But compared to DNA and RNA, changes in protein activity can more efficiently evaluate the mechanism underlying drug sensitivity and resistance. Phosphofluorimetry is a very powerful technique that measures protein phosphorylation events at the cellular level. So what do we do? The overall goal of this project is to build an application that can directly be applied on patients. So that's why our data is directly from the clinical trial. So let's say this is a new patient that we just want to decide if we want to use this rublisib on her or not. So first, we want to take the blood sample from her. Then we separate PBMC cells from the whole blood sample. And then we measure the phosphoprotein profiling using this p-fluorimetry. Important proteins, biomarkers, were pre-decided by prior biological knowledge and also the machine learning techniques that we found in the training process. After that, we can convert this phosphoprotein profiling to data record, to numeric data record. And we can input this p-flow data of this certain patient into a well-trained machine learning model, then get a predicted response. But how do we get this well-trained machine learning model? In our project, we use data from a second phase clinical trial to train a machine learning model, including 55 patients with 30 phosphoproteins. These 30 proteins are pre-decided by biological knowledge. The training labels were set to as responder and non-responder, and I'm going to explain that later. After that, we'll make the treatment decision based on the prediction. The predicted value will be responder and non-responder. So if it is responder, we will try to use this drug on this patient. If not, we will withdraw this treatment because the time of the patients are so valuable. So we have talked about so many of these things, but the key of this thing, the whole project, is about this machine learning model, right? So here are the training data and the validation data. As I said, this data are from a clinical trial. So there are pros and cons. Pros means that data is very true and it can be directly applied on patients. However, the cons is that we don't have so many patients and you cannot force patients to take your drug, right? So in the training set, we have totally 40 non-responders and 15 responders. The responder and non-responder, as I asked yesterday during a question session, they have very clear criteria. In our case, we use this tumor cell percentage reduction as the criteria, which means that after using this drug, how much tumor cells are reduced in the patient's blood. And for the validation set, very unfortunately, we only have responders. And these patients are not only treated with vubrlisib, but also with something else called acalabrutinib. But that's the real world, and you cannot force other people to take drugs. So here are two challenges. First of all, small sample size, as you already seen here. Secondly, the class are very imbalanced. That raises the challenges about machine learning, and many metrics, evaluation metrics of machine learning cannot directly be used in this kind of imbalanced classes. So we did many of this kind of adjustment to make sure that our results are trustful, reliable. So since this is an application that it might have potential to use on patients directly and we need to communicate with doctors, we aim to make this model simple, and as the most important thing is to easy to interpret. So we used Lasso. I think many of you may know it. It's a very powerful tool in computational biology. And the best thing of Lasso is it can shrink the non-important features, the coefficients of non-important features into zero. So we can find some important biomarkers. So first of all, we used leave one out cross-validation to evaluate if we can use phosphoprotein data to predict the treatment response. In fact, that's not the only omics data we used. We also tried to use RNA sequencing and drug-specific score, and also immunophenotyping, but none of them have a better result than phosphoprotein. And we also tried to combine them together with some easy tasks such as Z-score, but that didn't really work. So, but as you can see here, the p-flow actually gave nice prediction. So after that, we tried to train the entire training set with an entire Lasso model. And after that, the Lasso will give you the biomarkers that it selects. And after that, we use this model and predict on the independent validation set. So here are the results and the discussions. So as you can see from here, the RAW curve are quite nice, actually. The area under curve equals to 0.815, which is very acceptable. However, as I mentioned, that we have very small sample size. So according to this article here, that it says that AUC and RAW curve is not a very good metric when your sample size is very small. So additional thing must be done. So that's why we use this DeLong's test and bootstrapping to generate a confidence interval of our RAW curve. So according to this article, that the confidence interval should never contain the random selection line, which is the diagonal line you can see here. So as you can see from here that our result, the confidence interval is from 0.678 to 0.952, so not including the random accuracy of 0.5. And as you can see from the right side, that we also draw this PR curve, precision recall curve, and the area under that curve is equals to 0.71. But since that the baseline of this PR curve is the proportion of the positive class, which is 0.273, ARPOC of 0.71 should be considered as a very good result. And since I said this sample size is really small, it might be that our prediction just merely coincidence. So to prove that we are not merely coincidence, we also try to random label our data and bootstrap for 100 times. For each random labeling, we kept the proportion of each class as the same as the real data. As you can see on the right side, this is just from one random sampling. And both the RAW curve and the PR curve are nearly to the baseline. And as you can see from the left side, that ARPOC of the distribution of ARPOC for the 100 times, the average ARPOC is near to 0.2, which is also near to the baseline of ARPOC. So we also did some external validation, as you'll see from previously that we have this one-class validation set. So due to the absence of non-responder in the independent test cohort, the proportion of the positive class, which is responder in the training cohort, was employed as a cutoff probability to predict a responder. And why do we do that? So here's my thinking. Actually, this topic is quite complicated, and there are papers about it, but this is a simplification saying that a simple guess in the training cohort is not 50-50 chance. If you randomly guess a sample in the training set, you should always guess net responder, right? They have much more better probability. And so in that case, if the predicted probability is above the proportion of positive class, which means that the covariates, for example, of proteins, that lead you towards to the direction of a responder. So in that case, I would say any predicted probability above 0.27 will be considered as a responder. Of course, there are other kinds of cutoff choices, and there are papers about that. And however, I think there is a very famous one published in 2020, which published by Tianjin University in China. But however, that matrix used the predicted probability in the test set, so I will not use that at this moment, but I do consider to use it. As you can see from here, that all the samples in the validation cohort are correctly classified as a responder. And the distribution of the responder in the validation cohort here, it has no significant differences between the responder in the training cohort. However, it has significant difference between the non-responder in the training cohort. So that means that these two responders, they follow the certain kind of distribution, but they are different with the non-responders. This means that this indicates that our classifier successfully and robustly distinguished responder and non-responders. And finally, the biomarker selection. The Lasso algorithm identified 5 out of 30 phosphoprotein as potential biomarker for predicting treatment response. In fact, we try to use t-test to try to find the differentially, it's not expressed, but I just use that word, differentially expressed protein in the training set. Actually, there are 8, but only 4 of them are selected by Lasso. And one important protein selected by Lasso is not significantly different between the responder and non-responder. This means that the machine learning may detect potential biomarkers that traditional statistical methods might overlook. So finally, a treatment outcome score can be calculated by standard Lasso equation. At the end, there are conclusions. We present a machine learning approach to predict clinical outcomes of abrasive treatment on CLL patients. Our findings highlight the predictive potential of targeted proteomics data, suggesting its possible application in personalized treatment guidance. Feature selection tool identified specific markers for clinical outcome score computation. For small cohort, which is the most common case in clinical settings, metrics such as AUC should be tailored very carefully. To enhance our model's robustness and accuracy in the future, we aim to incorporate additional omics data although we have already did, but we will use them in a more smart way, including RNA-seq, drug sensitivity score, and immunophenotyping. And that's all, and thank you so much. And questions and comments are welcome, and these are the authors of this manuscript. And here are some things about Oslo in Norway. This is the hospital that I'm working in, and Aurora, and welcome to Norway if you really want to see snow and northern light. Thank you so much.
Thank you so much for the very interesting talk. So now I'd like to open up to the floor for any questions.
Hi. Very good presentation. Really enjoyed it. I was just wondering about the actual technology itself. It's the first time I ever heard something called phosphoflow cytometry. I was searching it up. How did you guys validate your results? Because I guess for that modality itself, you might need another data set in order to claim that results are correct.
Excuse me, could you please just a little bit closer to the mic?
Okay. Sorry, did you hear the first part of it?
To be honest, not really. Could you
Okay, sure, I'll restart. Yeah. So it's the first time I ever heard phosphoflow cytometry.
Yeah.
And then I was wondering for that modality itself, in order to claim that your biological results are actually meaningful, you might need to have a validation data set in the sense that it's not the model itself, but more about the modality.
Yeah, I see.
So did you guys test it on say, normal flow, mass cytometry, or mass spec?
Yeah, I would suggest you to check this paper, which is published by our collaborators. This one, it actually explained why phosphoflow protein is very useful and why it can actually be better in treatment response prediction.
Yeah, I mean, did you guys also validate your results? Because getting a modality from D doesn't necessarily claim
When
that
you
it's also
say
correct.
validate, may I ask what exactly that means?
So for analysis papers, usually you validate your results. For example, if you were to do clonal selection, to do clonal studies on cancer, if you have single cell RNA data, usually you also do a bulk analysis.
Mm-hmm.
So did you validate your results in our modality?
Yeah. When you say book analysis, I assume that you're talking about book RNA, correct?
Yeah.
Yeah.
So usually when you have single cell, you also do bulk to validate your results. And I was wondering, how did you validate your actual biological
Yeah,
findings?
first of all, I'm not a biologist. I didn't do this experiment myself. I'm a computer scientist. And this phosphoprotein profiling is very mature, and it has been I would say well known, but it's already published on a very high impact journal and be validated by peer reviews. So I do not know the details of experiment, but I trust the result. And if you think this is kind of like potential problem, I think I would like to suggest you to check this paper, which will explain it very well.
Okay.
Yeah,
Thanks.
thanks.
Hi, great talk. Actually, I'm just wondering, because you showed the sort of the box plot with the predicted probabilities. No, I was actually wondering whether you took a look at the sort of like the distribution of the external validation data set with yours to start with. I think it's on like the greater set. Essentially, have you like done like a PCA, for example, to see whether there's any differences in the cohorts or the validation sets, for example?
When you say PCA in the validation cohort, do you mean that we use this 5 selected protein to try to see if they're to build a PCA plot or something?
Even the full like 33 proteins, is it? It's like essentially the full data set just
Yes.
to see whether there's any confounding effects. Because at the end of the day, it's also one of the sort of answers to the previous question to see whether like if you run it in 2 different countries, is there a lot of differences based on the technology or anything else?
Well, actually, the technology are the same between the training set and the validation cohort because they are obtained by ourselves, by our labs. And but the blood sample and the treatment are totally different from different cohorts.
Yeah.
And when you say to use this PCA to validate, sorry, I didn't do that. But I would consider about this to try to see if there's a potential distribution inside.
Okay, great. Thank you.
Yeah, thank you so much.